the topic allotted to me is multimodal imaging in the analysis of adult onset foveomacular vitelliform dystrophy and compared to acquired vitelliform lesions. Now, as retina surgeons, we are all conversant with a vitelliform lesion as typically seen in Best disease, and we know the different stages. That is, you have the vitelliform, the pseudohypopia on the scrambled egg, and the atrophic phase. But we are also aware that this is something that you would see in a patient in the first 2 decades of life. At the same time, we are also aware that we do see patients with vitelliform lesions well into the later decades of life, even the 6th, 7th, and 8th decade of life. And the reason for that is has been allocated to 2 different conditions. One is a dystrophy, that is the AOFVD, and the second is the acquired vitelliform lesion. So let's look at each of these. Now, AOFVD has been described almost 40 years ago by Gass, and in his description in 1974, he described the demographics as a patient between 30 to 50 years of age, bilateral yellow lesions, who then later go on to develop RPE and photoreceptor atrophy, but they do have normal electrophysiology and autosomal dominant trait. Now, this was his initial description. So let us look at the imaging findings. So as usual, one would describe the color images first. And what you see on the left is the classical presentation where you have bilateral, symmetrical, small yellow lesions in an adult patient. These lesions are typically a third or 25% of the size of the disc. And these later on go on to develop larger atrophic areas. Going on to autofluorescence, one would see that the area of the vitelliform lesion typically shows hyperautofluorescence, and this helps to differentiate the area where the lesion is dome-shaped on SD-OCT. But at the same time, the autofluorescence pattern can be varied. It can be patchy, focal, ring-like, and linear. So different patterns besides the standard round pattern corresponding to the lesion have been published in the literature. On infrared imaging, also you can see patchy lesions, and there is some evidence in some published articles that a patchy pattern on autofluorescence as well as on NIR imaging has a worse prognosis. Going on to fluorescent angiography, there are 2 broad patterns which you will see. One is in the early phase where there is block fluorescence. This is attributed to the vitelliform lesions, and subsequently there is staining. Now, this staining is of importance because on one hand, it can be mistaken as an occult choroidal neovascular membrane, and at the same time, you may actually miss a choroidal neovascular membrane if it is present, because you may say that it is staining of the vitelliform lesion. So to help in that, one can do an Icg angiography, and as you can see on the top left, on Icg angiography, in a typical vitelliform lesion, you would not see anything other than hypocyanescence. At the same time, it can be useful, as you can see in the lower right, where the lesion on fluorescein shows a pattern of occult neovascularization, and in fact, there is a very large hypercyanescent lesion on Icg angiography. So Icg can be used as an additional modality if you suspect that there is a neovascular change under the lesion. Of course, the classical description is for SD-OCT, and the initial stage is that of a dome-shaped lesion. This dome-shaped lesion contains a uniform hyperreflective material which separates the RPE from the photoreceptor layers. This subsequently goes on to break down, and you would see areas of hyporeflectivity. And then as the photoreceptors as well as the RPE atrophy, you would see a collapse of the lesion, but you would also see hyperreflective lesions in the inner retina, and this is related to migration of macrophages and RPE cells. Of course, in the end stage, there is atrophy of the RPE as well as the inner and outer retina. So this is just a description of the 2, and the important thing is, of course, is that loss of the ellipsoid zone or the integrity of the ellipsoid zone correlates with a dramatic drop in vision. On en-face imaging, what you would see is, again, concentric rings, and these concentric rings correlate to the hyperreflectivity on the B scan on SD-OCT. EDI, there is one report which says that there is subfoveal choroidal thickening in patients with AOFVD as compared to patients with acquired lesions in AMD. OCTA can also be useful as an additional modality, as this particular case highlights, where you have the appearance of the dome-shaped lesion on SD-OCT, and on fluorescent angiography as well as on Icg angiography, there is no convincing evidence of a neovascular membrane. But as you can see on OCT angiography, there is a very clearly defined membrane. So therefore, one can use the entire spectrum of imaging modalities depending upon what you are suspecting after the initial examination. Now, just to understand the vitelliform lesion in an adult patient, one has to keep in mind that there is the RP photoreceptor complex, which is normally kept intact because of the continuous phagocytosis of the outer segments. And any pathology which disrupts this can lead to the formation of a vitelliform lesion, and that is the genesis of the acquired vitelliform lesion. As compared to the degenerative and dystrophic processes, you just have a collection of material, and this material is the outer segments, lipofuscin, melanin, macrophages, and RPE cells. And this is what gives you that homogeneous, dense, dome-shaped elevation. Subsequent to that, there is actually atrophy or loss of the photoreceptors. And because of loss of photoreceptors, the remaining material is now phagocytosed and removed by the RPE cells. And therefore, you see an apparent clearing of the material. But continuously going on into the disease, there is both atrophy and death of the photoreceptors as well as the RPE cells. And that's when you see the collapse stage. So this is an example where you're visualizing the pathology with your imaging techniques. Of course, there are certain confounding conditions. Like in AOFVD, you may see that in elderly patients. They may present with metamorphopsia, neovascular membrane, and RPE detachment. Like here are two patients with AOFVD. These patients have cuticular drusen as well as multifocal lesions, so one may mistake them as something else. And in fact, the differential diagnosis of acquired lesions can extend to systemic diseases, toxic conditions, paraneoplastic conditions, and more importantly, the common conditions which you would come across, that is AMD, CSC, and tractional maculopathies. And there is evidence in the published literature to suggest that there is documented confusion, like this particular patient of CSC, which was mistaken as AOFVD. And this patient who was initially diagnosed as AOFVD was then turned out to be a case of CSC, all because of the misinterpretation of the vitelliform lesions. So therefore, one has to look into a variety of differentiating factors, including the age, the symmetry, the size, and associated complications. And here are just a few examples which have been shown in the previous presentations, like you have the appearance of the typical drusenoid or reticular drusen, as they were previously called, and you have epiretinal membrane as well as vitreomacular traction causing the appearance of vitelliform lesions, and secondary to certain drugs as a toxic retinopathy. And this, of course, is a detailed chart, but it has been described in the previous presentations. Just one point to highlight, which has been mentioned in this article by the Januzzi group, where they've described the appearance of choroidal neovascular membrane in acquired vitelliform lesion, and they have described the sign of what is known as the two-zone or the split layer between the RPE and the basal lamina, and this is a precursor to the development of choroidal neovascular membrane. What they've said is, of course, that this appears only after absorption of the dome-shaped lesion. So what we knew in the past was the characteristics of Best disease, and we do know that vitelliform lesions can occur in the adult patient. What we know now, that adult onset FVD is a distinct entity, but it can also present in older patients in their 6th and 7th decade and therefore cause confusion. But all these diseases have a common pathway of separation of the RPE and photoreceptor complex. And patients with acquired lesions have a higher risk of developing subretinal neovascularization. What we do not know is the exact clinical parameters to define adult onset FVD. And are patients of adult onset FVD who have drusen and develop neovascular membrane, are they a subset of AMD? and why, though the initial description of AOFVD was autosomal dominant, some patients do not show this pattern. And therefore, we are still to understand the exact pathology which disrupts the RPE photoreceptor homeostasis, and a better understanding of this with imaging will help us to clinch a diagnosis at initial presentation and therefore manage these patients better. Thank you.